Hello, I'm Dr. Darren McGuire. Welcome to More Than Lowering Blood Sugar, Protecting Your Heart in Type 2 Diabetes. This series is provided by CME Outfitters and is supported by an educational grant from Novo Nordisk, Inc. This is the second of a three-part education webisode series and will cover strategies to address type 2 diabetes and reduce cardiovascular risk. Again, I'm Dr. Darren McGuire. I'm a professor of medicine at UT Southwestern Medical Center in Dallas, Texas. I'm a cardiologist, and I've spent the last 25 years focusing both in my clinical activities as well as in my research on diabetes as a cardiovascular risk and condition. As we learned in webisode 1, type 2 diabetes puts patients at increased risk of cardiovascular disease. The good news is that knowing about the heightened risks that come with diabetes, we can map out a plan that works for you to help protect your heart health. Here are some key action items that we'll be talking about through this presentation. It's important to maintain heart-healthy eating and regular physical activity, regular exercise, achieving and maintaining a healthy body weight, avoiding tobacco, including exposure to other people's smoke, monitoring and managing key risk factors, including blood pressure, LDL cholesterol, in and above and beyond your glucose control. These are all important features of the management of type 2 diabetes, and the blood pressure and cholesterol control is equally important as managing the blood glucose. Taking actions to reduce stress. Stress increases cardiovascular risk. Taking medications as prescribed. We'll talk about some of those medications that can powerfully affect your cardiovascular risk. And committing to regular follow-up visits with your clinicians to monitor your success at both lifestyle interventions and the adherence to prescribed therapies. Of course, making any change in life can be difficult. The therapeutic lifestyle interventions that we recommend are not always easy. People are challenged with a lack of time to implement the healthy activities that we encourage, like regular physical activity. Patients can feel overwhelmed not knowing where or how to start, setting realistic goals, and enlisting support from others. Some of the recommendations can increase cost if you need to buy exercise equipment or clothing, or join a gym, or buy healthier but still more expensive foods. We understand that these are all challenges of adopting and adhering to therapeutic lifestyle interventions. Factoring in other health issues you're managing. People with type 2 diabetes often have multiple health conditions that require management all at the same time. And not fully understanding the link between diabetes and heart disease. This is the important feature that hopefully we'll get through this series of webisodes, really hammering home the fact that you have cardiovascular risk increased when you have type 2 diabetes. But to make you hopeful, as we are hopeful, we have very effective therapeutic interventions that can modify most of that incremental risk if applied effectively. We need to overcome the barriers. Barriers are all over the place to adhering to prescription for lifestyle intervention and for taking the medications. We encourage patients with type 2 diabetes, of course, to get yearly eye exams and to practice daily foot care to avoid the microvascular complications of type 2 diabetes. For cardiovascular risk, we encourage monitoring and management in addition to blood glucose control, monitoring and management of blood pressure and of LDL cholesterol. Focusing on heart health and heart healthy habits throughout your daily living, getting support from clinicians and from other support groups, and taking charge of your own health, being aware of your risk factors and monitor your success at modifying them. And ask about medications. Ask your clinician about medications that address cardiovascular health as well as hyperglycemia when you're talking about your management of type 2 diabetes. Let's talk about the medications we have available, from the tried and true to the newer therapies. Now, again, independent of blood glucose, persons with type 2 diabetes, almost every adult with type 2 diabetes should be on a cholesterol-lowering medicine called a statin. These have been shown across the field of across the spectrum of diabetes to favorably affect cardiovascular risk. For people with atherosclerotic cardiovascular disease and type 2 diabetes, it's important to take a low-dose aspirin daily. Be sure to talk to your clinician whether you have eligibility for a low-dose aspirin. We are using aspirin less commonly these days in people without who have not had a heart attack or a stroke, and so that will be up to your clinician. Maintaining blood pressure control, that we have a series of blood pressure medication classes that have been proven effective, not just at lowering blood pressure, but at reducing risk for adverse cardiovascular complications, including heart attack, stroke, and heart failure. Key among them in patients with diabetes are the classes of medications called ACE inhibitors or angiotensin receptor blockers, so ACE inhibitors or ARBs. These medications, in addition to cardiovascular risk reduction, also favorably affect kidney disease risk in patients with diabetes. And so these tend to be first-line blood pressure therapies for persons with type 2 diabetes. We now have two classes of anti-hyperglycemic drugs or diabetes drugs that have proven cardiovascular benefits that are above and beyond their effects on blood glucose. So even if you don't need additional glucose control, these medications are now recommended for every adult with type 2 diabetes who have increased risk or have manifest atherosclerotic cardiovascular disease or heart failure. These include the GLP-1 receptor agonist, the GLP-RAs. I'll be talking about them, abbreviating them, and the sodium glucose cotransporter 2 inhibitors, or the SGLT2 inhibitors. The GLP-1 receptor agonists are all injectable except for one exception, which is a tablet. The SGLT2 inhibitors are all once daily tablets. The most commonly prescribed diabetes medicine, metformin, it's common and it's an effective medication to lower hyperglycemia. It's the most commonly used medication for hyperglycemia around the world, and it's often the first line treatment for type 2 diabetes. But unfortunately, we do not have evidence that metformin affects cardiovascular risk. About 80% of patients who are on one medicine and only one medicine for diabetes do take metformin. But in a large study intended to reduce the risk of progression to diabetes among persons at high risk, after 21 years of follow-up, there's no detectable risk effect of metformin with regards to major adverse cardiovascular events. That is, metformin did not reduce cardiovascular risk despite reducing the risk of progressing to diabetes. So early use of medications that treat diabetes and have also been proven to reduce cardiovascular risk is an important conversation to have with your clinician. These drugs I mentioned, the GLP-1 receptor agonist and SGLT2 inhibitors, should be considered independent of metformin use, and they even now can be considered as first-line therapies for people at high risk or who have atherosclerotic cardiovascular disease. The SGLT2 inhibitors, again, these are once daily tablets. They lower blood glucose by causing glucose excretion in the urine. They have secondary benefits of weight loss, and they lower blood pressure and circulated intravascular volumes or fluid levels. This leads to less stress on the heart and kidneys, and these SGLT2 inhibitors have been proven to potently affect the risk of developing heart failure, the risk of kidney disease progression, and the risk for heart attack and stroke. And so these are some of the most potent cardiovascular medications we've ever had. And again, these effects are independent of their effects on blood glucose. The GLP-1 receptor agonists have secondary benefits of weight loss, lowering blood pressure, and favorably affecting cardiovascular risk as well. There's a possibility that these drugs, independent of their effects on glucose, have direct favorable action on the lining of the blood vessels themselves and reduce the development and progression of atherosclerotic cardiovascular disease. Across the class of GLP-1 receptor agonists, there's clear benefit for risk on atherosclerotic cardiovascular complications of cardiovascular death, heart attack, and stroke, really important clinical outcomes. If you start on an SGLT2 inhibitor or a GLP-1 receptor agonist, your doctor may stop or adjust the dose of other medications you're using for the treatment of hyperglycemia or high blood glucose. So let's look at the totality of the data without getting too much into the weeds, just to underscore the importance of these two classes of medications. First, the sodium glucose cotransporter 2 inhibitors, SGLT2 inhibitors. There are 4 medications in this class approved for prescription in the United States. All 4 of them have undergone formal cardiovascular outcomes testing. All 4 of them have been proven safe from a cardiovascular risk perspective, but 2 of the 4 of them have proven risk reduction. Empagliflozin and canagliflozin both reduce the risk for cardiovascular death, MI, and stroke. And so this class of medications became the very first class of medications for the treatment of type 2 diabetes ever to be shown to reduce cardiovascular risks. And so this class of medications represents a quantum leap forward in the cardiovascular care of persons with type 2 diabetes. And so the risk reduction is somewhere around 15% relative risk reduction for cardiovascular death, heart attack, and stroke. If you're taking an SGLT2 inhibitor, there's a few minor issues to consider. These drugs are very well tolerated with very few side effects, but a few things to keep in consideration is to stay hydrated. These are weak diuretics, but they are diuretic medications, so stay hydrated. Report any dizziness or fainting feelings or foot ulcers to your clinician. On any day that you're not eating a normal amount, if you're fasting for health purposes or for medical procedure or for religious purposes, or if you're sick to your stomach and just not eating, on those days that you're not eating a normal amount, we recommend holding this class of medications just while you're not eating, and you can resume when you resume eating a normal amount. Also, watch for signs. The SGLT2 inhibitors do increase the risk of genital yeast infections. These are almost always mild and can be treated over the counter, and very uncommonly are recurrent. And so just know that there is an increased risk for yeast infections. This applies to men and to women, and just encourage to redouble urinary hygiene if you're taking an SGLT2 inhibitor. Switching now to the GLP-1 receptor agonist. Again, these are typically injectable, either once daily, or most of them now are once weekly injections. In addition to lowering blood glucose, we've discovered a number of what we call pleiotropic effects, or side effects that are favorable for this class of medications. The GLP-1 receptor agonist can reduce heart attack size, have some slight antiplatelet activity, favorable effects such as we get with aspirin. It reduces after we eat. We have very high levels sometimes of triglyceride in the bloodstream, and GLP-1 receptor agonists reduce those excursions. They're anti-inflammatory in action, again, independent of their glucose effects. The GLP-1 receptor agonists will work on the satiety center of the brain, the part of the brain that tells you that you're no longer hungry. And because of that, they induce weight loss. These are the most potent weight loss drugs we've ever seen. And again, that's independent of their effects on blood glucose. There's a small blood pressure beneficial effect with GLP-1 receptor agonists, 2 to 3 millimeters of mercury. So not as much as most blood pressure medications, but it's certainly complementary. And again, we've completed a series of randomized clinical trials evaluating the effect in patients with type 2 diabetes of the GLP-1 receptor agonists, evaluating their effects on cardiovascular complications or risk. And what we've seen is these drugs, much like the SGLT2 inhibitors, add an additional 15% relative risk reduction for cardiovascular death, MI, and stroke. Based on the SGLT2 inhibitor data and these data with the GLP-1 receptor agonist, these drugs have now become what we call a level 1A recommendation in all guidelines of the care of persons with type 2 diabetes with multiple risk factors or with atherosclerotic cardiovascular disease. These drugs should be used in all such patients unless there are contraindications or intolerance. This goes to the point that it can even be used, either one of them or both, ahead of metformin in selected patients. Most patients do very well with these medications, but there are a few things to consider when starting or taking a GLP-1 receptor agonist. These medications can slow how quickly food leaves the stomach. This is a good thing because when eating, you feel full faster and don't eat as much. And so that's one way that these drugs also, in addition to their effects directly on the brain hunger centers, can affect weight loss. If you eat too much or too quickly when taking a GLP-1 receptor agonist, you may feel overly full or even nauseated. Be sure to report any vomiting to your clinician. Vomiting is a known side effect of these drugs. It happens in very few patients, but when it happens, it's important to let the clinician know because excess vomiting can lead to other health problems. Because of the nausea and vomiting associated with the initiation of these medications, we tend to start at the very lowest dose and titrate up to the target dose of the GLP-1 receptor agonist slowly, usually over a period of 4 or even 6 weeks, walking slowly up to the target dose of the medications. Almost everyone will develop some nausea when they start these medications, but virtually in every case that goes away after 1 or 2 weeks. It's seldom prohibitive, but you do have to expect that will occur. That actually means the drug is working. And we can walk you through that with expectations, and so that you will continue to stick with the medication and get through the nausea part. And typically, once it goes away, there's no longer a problem of nausea as you get onto these medications longer term. I often hear certain questions over and over from my patients with type 2 diabetes when we're talking about their cardiovascular health and risk. Specifically with the GLP-1 receptor agonist, do I need to inject these medications? How often and how big is the needle? The SGLT2 inhibitors, as I mentioned, are tablets once daily. There is one GLP-1 receptor agonist, semaglutide, that is available in the oral formulation once a day. All of the other GLP-1 receptor agonists are injectable, either once daily, and as I mentioned, most of them now are once weekly. The needle is tiny. Not only does it not hurt much, you can actually not feel it enter the skin. You have to watch the needle go into the skin, or actually make sure you've got the device, the pen, the injection pen, firmly against the skin to be sure that you're injecting yourself. And it is a very, very minor deal to inject these medications. There's little to no discomfort whatsoever. And as I mentioned, there is one oral version of semaglutide for persons who simply cannot get themselves to inject a medication. What happens if I skip a dose? Typically for the once weekly injections, we encourage, when you realize you've missed a dose, to go ahead and take that dose. They don't have to be separated exactly at 1 week intervals. And so because they're so long acting, missing a dose over a 1 or 2 day period of time does not matter. If you miss a dose of the once daily injection, typically we would just have you to skip that dose and resume the next day. Will these medications cause low blood sugar? Neither the SGLT2 inhibitors nor the GLP-1 receptor agonist alone cause hypoglycemia or low blood glucose. They do slightly increase the risk of low blood glucose when they're added to either insulin or sulfonylurea medicines. I think this graphic from the American College of Cardiology is a good way to summarize our conversation today. First, the foundation of treatment of type 2 diabetes with regards to cardiovascular risk is lifestyle intervention, healthy eating, achieving and maintaining as healthy of a weight as you can, and exercising as frequently as you can. Metformin will be used in most people as the first line therapy. It doesn't have to be first line. But it will be in probably 80% of the persons. If you're on metformin and your clinician's considering a GLP-1 receptor agonist or an SGLT2 inhibitor, they will typically simply add that medicine to metformin as the background medication. Other medications specifically to lower cardiovascular risk should be considered independent of blood glucose, the need for more blood glucose control. Again, even if your blood sugar is completely perfectly controlled, we do want at least the clinician to consider the SGLT2 inhibitors or GLP-1 receptor agonist if you have high risk for or manifest cardiovascular disease. And of course, modifying the other risk factors, as we mentioned, for persons with indication in antiplatelet therapy like daily low-dose aspirin, maintenance of good blood pressure control and maintenance of good LDL cholesterol control are key to reduce risk for cardiovascular complications of type 2 diabetes. So I want to thank you for participating in webisode number 2. If you haven't done so already, please check out webisode 1, which explains the relationship between diabetes and cardiovascular disease. And don't forget to tune into webisode 3 with Kimberly Ellis, also known as Kim E, the Diabetes NP, who will share ways to be more engaged and proactive during visits with clinicians, including questions to ask about your heart health. Thanks again, and stay well.